we know that status epilepticus is complication of cardiac arrest. So epileptiform EEG occurs in about 20 to 30% of cases. In some of them, this is definitely a negative prognostic sign, particularly if there is a periodic pattern on EEG. But there are some patients with properly defined status epilepticus according to the status criteria, and these patients may have favorable prognostic indicators. We don't have specific treatment for this condition. We know that it's highly refractory, but a novel treatment is needed. That's why we are doing the SuperCAT study. So we are employing this dual anti-glutamate strategy to block simultaneously the NMDA receptor with ketamine, which is an anesthetic drug, and AMPA receptor with perampanel, which is an anti-seizure medication. We do the SuperCAT protocol only for super-refractory status. So this means that patients have already failed at least one anti-seizure medication and one anesthetics. So we need basically another anesthetic and another anti-seizure medication. So this combination is potentially very effective because it blocks the major neurotransmitter for excitation in the brain. And it is something feasible because both of these drugs are readily available in hospitals from Western countries, at least. So we are choosing this condition because we know that it is one of the most difficult to treat status epilepticus. We think that this treatment could be potentially applied to other etiologies as well. But at the moment, we gained quite some years of experience in treating these cardiac arrest patients with favorable results. So we are continuing with this kind of etiology at the moment. So currently the SuperCAT story is a multicenter retrospective study involving 10 centers in Italy. And we compare patients treated with the SuperCAT protocol during the ICU stay to patients treated with any other combination of anesthetics or anti-seizure medications during the ICU stay, but without ketamine and without perampanel. So the primary endpoint is the resolution of status epilepticus during the ICU stay. And we assess also as secondary endpoints clinical efficacy in terms of awakening in the ICU, so up to following commands, and then disability at 6 months, so independent living 6 months after cardiac arrest. So in terms of resolution of status epilepticus, the SuperCAT group has about 80% probability of resolution, which is very high, compared to about 40% in the others group, so including any other combinations. So the difference is quite impressive, and this is exactly what we are seeing in the last about 10 years, because we started the first patient with this kind of schedule we treated in 2015. So it was a young patient, and in this case was a kind of serendipitous finding, let's say, because the status epilepticus was very difficult to treat, but she had good prognostic signs. And so at the end, we employed this schedule and it worked very well. And after this case, we started to do more patients. Then in our center is actually the second line treatment, so it's kind of routine care. But we are exporting, let's say, this schedule in other centers in Italy, and doing this basically we started this retrospective study that is now about to finish. We want to recruit 100 patients in total with this condition. And at the moment, we have data of 57. So we still miss a while, but we basically wait for data to be entered in the next few months. So we should finish this retrospective phase quite soon. As far as clinical outcome, we have a trend at the moment, a trend favoring the dual anti-glutamate treatment with an odds ratio of about 2 to 3 compared to the others treatments, both for awakening and for independent living at 6 months. The confidence intervals are still quite large, so this make us still a bit unsure of a positive effect, but the trend is in that direction, definitely. Then we explored safety of this dual anti-glutamate treatment, and actually the only safety signal we saw was a raise in the liver enzyme gamma GT, which was very common in the super-cat group, and we think this reflects the oral loading of perampanel, which we employed at the dose of 12 milligrams per day for 5 days, and then it was gradually tapered. This liver enzyme actually was just a laboratory finding, so it was not required to do any specific treatment. It just went away after tapering. We didn't have any other safety issues, and actually mortality was much higher in the others group compared to the super-cat group because the status epilepticus was not resolved, and this usually basically led to death. The super-cat protocol is conceived as an acute treatment that lasts a few days. So ketamine is given for 3 days, and then it is stopped. So the patient is anesthetized for 3 days, and it is monitored continuously with EEG because ketamine, the dose of ketamine is adapted to the EEG response to reach the target of ketamine pattern. And perampanel is given for 5 days, 12 milligrams per day, and then it is gradually tapered by 2 milligrams every 2 days until it is stopped. And so it is, a long acute treatment, but it is not an acute, a chronic treatment. So this is something that it should be done just in the ICU. It will not last after the ICU stay.